Hello again, everybody. This is Dr. Pientka from theorthopods.com. Today I'd like to talk to you all about one of our orthopedic emergent conditions, and that's compartment syndrome. Compartment syndrome occurs when there's an increased pressure within the fascial spaces of an extremity, and that leads to a decreased diffusion of blood to the muscles and nerves within that compartment. This decreased perfusion can cause irreversible damage to muscle within the compartment if not addressed in a timely manner, which is what makes compartment syndrome an emergent condition. The way I like to describe the pathophysiology of compartment syndrome to my patients is basically the fascia creates a three-dimensional space, a volume, that can't extend past a certain extent. And once that maximum volume is reached, then the swelling starts to compress things within the fascia. And this essentially cuts off the blood supply to everything within those fascial boundaries. Compartment syndrome is a condition that was originally described by Volkmann back in the 1800s. He noted as a result of bandages that were too tight, eventually these patients developed contractures of their limbs. And this is what we now know is a Volkmann contracture. And what Volkmann was actually describing was a contracture that was a result of a missed compartment syndrome. According to the OTA, the definition of compartment syndrome is symptoms resulting from increased pressure within a limited space, which compromises both circulation and function. The pressures within the compartment increase and will eventually exceed the intramuscular arteriolar pressure, and therefore blood can no longer fill capillaries and supply the muscle. The end result of this is muscle necrosis. The reason that it's important to identify compartment syndrome immediately when it's present is there's a relatively short amount of time until you start to see severe damage and changes to the musculature within the compartment that has compartment syndrome. Hargens published a study in JBJS in 1981 showing the time course and the extent of damage to muscle when it's ischemic. At 4 hours of ischemia, he noted reversible damage to the muscle. At 8 hours, he noted irreversible damage to the muscle. And there was variable damage to the muscle from 4 to 8 hours of ischemic time. This study is largely where our time frame for identifying and treating compartment syndrome came from. After 4 hours of ischemia, you start to see a myoglobinuria, which can lead to high urinary output renal failure. You also get cell death, which leads to a vicious cycle of increased capillary permeability, which further increases muscle swelling and pressure within the compartment. In another JBJS article from the late 70s, Hargens showed the changes that occur in a nerve with various durations of nerve ischemic time. At 1 hour of ischemic time, there was still normal conduction within the nerve, but there was reversible neuropraxia type damage from 1 to 4 hours of nerve ischemia, and after 8 hours of nerve ischemia, they noted irreversible changes within the nerve. So what physically causes the increased pressure within the compartments? There are a number of causes of compartment syndrome, and they can be either internal or external, or a combination of both to cause the compartment syndrome. Internal causes of compartment syndrome come from increased volumes within the fascial compartments, and this is usually from hemorrhage from a fracture, but it can be due to swelling in the body's response to burns or ischemic swelling after revascularization procedures. The ischemic swelling after revascularization is the reason for prophylactic fasciotomies after a revascularization. Hemorrhage into a compartment is usually from a fracture of a long bone, like a tibia or a femur or in the forearm. But a vascular injury to an artery can also cause rapid hemorrhage into a compartment, which leads to a compartment syndrome, or can lead to a compartment syndrome. Crush injuries are also common causes of compartment syndromes, even if there's no fracture, and this is due to soft tissue edema. Similarly, if a limb has been compressed for some time, you can develop a compartment syndrome from that as well. And you'd think about this in someone who's been found down for an unknown amount of time, either from a drug overdose or potentially even an elderly person who had a fall. External compression from a cast or a tight dressing can also cause a compartment syndrome. This is why, especially in pediatric populations who are treated acutely with casts, it's important to bivalve the cast to allow a quick decrease in external compression if necessary. So how do we diagnose compartment syndrome? Compartment syndrome is a clinical diagnosis. In order to identify a clinical diagnosis, you must have a high clinical suspicion. Based on the history alone, I find oftentimes my compartment syndrome spidey senses, if you will, are going off before I've even seen the patient. The people I worry most about developing compartment syndromes are gunshot wounds to the tibia, segmental tibia fractures, or young males who suffered a tibia fracture while playing football or another contact sport. These are the ones that have high impact high energy types of traumatic mechanisms. When I get a call about one of these patients, compartment syndrome's on my mind before I even laid hands on them. You also must do a thorough physical exam on these patients the first time you see them and document it, even if they don't have a compartment syndrome when you first see them, so you have a good baseline exam to compare to going forward. It's also important to have good documentation if you're not going to be the one who sees them going forward. If you're handing off care of this patient, which is commonly done, especially now with the resident duty hours, you need to hand off your trauma patient at the end of your shift. Someone else needs to know what their baseline exam was. Classically, the diagnosis of compartment syndromes involves the 5 P's of compartment syndrome. And we stress this to all the medical students that rotate through our department because this is what's tested. However, these signs are largely unreliable to diagnose a compartment syndrome by themselves. The 5 P's are pain. This is a pain that's out of proportion to what you'd expect for their exam. Of course, a patient that had a tibia fracture is going to have pain, but is that pain severely exacerbated or worse than what you would expect from somebody with a tibia fracture? Pallor or a cool pale leg, paralysis, pulselessness, and paresthesias are the 5 P's. So pain, pallor, paralysis, pulselessness, and paresthesias. The thing that my students always trip up on is you can have each of these individually without having a compartment syndrome. And you can also have a compartment syndrome without having all of these. In fact, paralysis, pulselessness, and even paresthesias come after an established compartment syndrome, and at that point you should have already identified it and be taking the patient to the operating room. It's important to remember that sensation changes in paralysis do not occur until after there's been at least 1 hour of ischemic time. The patient also may retain palpable pulses even in the face of an acute compartment syndrome. When I evaluate a patient for compartment syndrome, I first take into account the general status of the patient. For example, if I walked into the room and the patient's asleep, it's very, very unlikely that that patient has acute compartment syndrome. If the patient's writhing in pain and you can tell that there's extensive swelling of the extremity before you even lay hands on the patient, you need to be thinking that this patient could have a compartment syndrome. Now, when I was a young resident, I had a habit of doing compartment checks on patients that had a tibia fracture or something like that. And I'd walk in and ask them how they were doing, and they would tell me their leg hurts, and I would take their toe and I would move it and say, "Does this hurt you?" Inevitably, almost all of them said, "Yeah." Me passively stretching their ankle or usually their toe was painful for them. It wasn't until I got a little more experience that I realized the importance of performing the passive stretch while distracting the patient. If the patient jumps off the bed while you passively move their toe while talking to them about your plan for surgery the next day, for example, that patient likely has a compartment syndrome, or at least is in the process of developing a compartment syndrome. However, if the patient doesn't even wince at the passive stretch, it's very unlikely that that patient currently has a compartment syndrome. I've also made it a habit to compress compartments if I can, if they're not under splints or a cast, when I examine these patients. However, there's multiple studies that show this is an unreliable test in ruling out the diagnosis of a compartment syndrome. But trending the tightness of the leg or a compartment, however, can give you an idea of whether the patient is becoming more swollen and somebody you need to keep an even closer eye on. In our institution, we tend to use the Stryker compartment pressure monitoring system to confirm a clinically suspected case of compartment syndrome in the awake patient prior to going to the OR. If an intubated patient or an obtunded patient is somebody that you're concerned about, though, your Stryker compartment monitoring may be the only way that you can diagnose a compartment syndrome in these patients, because they can't tell you that their pain is out of proportion to their exam. If you've never used the Stryker device before, it's important to have this demonstrated to you before you're in a situation where you're going to be on your own and need to use it. It's important to remember to zero the device before obtaining your readings. It's also important to do 4 separate sticks in each of the 4 compartments of the leg. It's important to take compartment measurements at the fracture site, or at least within a couple centimeters, as studies have shown that there's a gradient of pressure. The further away you get from the injury site, the less the pressure. There's also 2 ways to use the compartment pressures to determine whether or not the patient has a compartment syndrome. The classic or original theory was the absolute pressure of greater than 30 millimeters of mercury would be indicative of a compartment syndrome. However, more recent data shows that the pressure gradient theory may be more accurate in the diagnosis. Currently, most orthopedists are using the pressure gradient, or the delta P, of less than 30 millimeters of mercury from the diastolic blood pressure. Basically what this means is if your highest compartment pressure measured, say, 55, and the patient's diastolic blood pressure is 90, it's not currently a compartment syndrome because the difference between the two is more than 30. The idea behind this is the theory that if the diastolic blood pressure is high enough above the compartment pressure, then the pressure within the capillaries will remain high enough to perfuse the muscle. Another thing that's important to remember if you want to use diastolic blood pressure is to use the blood pressure of the patient before they had their blood pressure artificially lowered in the OR by a general anesthetic or a conscious sedation or something like that. So for instance, if you measure a compartment pressure of 40 in the operating room and the patient's systolic blood pressure at that time is 40, the delta P would be 0. But if you use their preoperative diastolic blood pressure of, say, 90, then the delta P is 50, and this doesn't meet the criteria for acute compartment syndrome. Just because a delta P is not less than 30, however, does not mean you do not need to closely monitor that patient. The normal compartment pressures tend to be 10 or less, so once you see numbers in the 40s or above, this is indicative that the patient does have a significant increased pressure within that compartment, and this could quickly worsen and go on to acute compartment syndrome. I often get asked the question from our students, does an open fracture prevent compartment syndrome? And the answer to that question is no. Open tibia fractures still have about a 6 to 10% rate of compartment syndrome. And the reason this can happen is because the fascial defect caused by the open fracture does not completely release the fascia within the compartment or the surrounding compartments. So now you have your patient, you've diagnosed them with compartment syndrome. What do? Well, you should remove any bandages or splints or anything restrictive from the patient immediately upon arrival if you were suspicious of compartment syndrome. But once you've made the diagnosis, the patient immediately goes to the operating room for fasciotomies. Now, what compartments are normally involved in compartment syndrome? In the leg, it's the anterior or the deep posterior compartments. And this makes sense given that they're closest to the tibia and will have the most bleeding into them from a fracture. In the forearm, the most likely location for a compartment syndrome is in the volar compartment. Fasciotomies in the leg can be done in various ways. There's a one-incision direct lateral fasciotomy, but the more commonly used technique is a dual incision medial and lateral incision fasciotomy. Your medial incision allows you to release both the superficial and deep posterior compartments, and the lateral incision allows you to release both the anterior and lateral compartments. These incisions should be extensive, ranging from just distal to the knee to the level of the ankle. Thigh compartment syndrome is rare. The thigh has a lateral, posterior, and medial compartment and can usually be decompressed through one lateral incision type. The lateral thigh compartment is actually the anterior musculature, so this is the rectus femoris and the quadriceps muscles. The forearm compartments are the volar, dorsal, and then the mobile wad. The mobile wad consists of the brachioradialis, the extensor carpi radialis longus, and the extensor carpi radialis brevis. Again, the volar compartment is usually the infected compartment with compartment syndrome of the forearm. Fasciotomies in the forearm involve a release of the carpal tunnel and then an S-shaped incision over the forearm volarly to address both the volar and mobile wad. And if necessary, a straight dorsal incision can be used to decompress the dorsal compartment. This isn't usually necessary, however. In the forearm, it's important to release the fascia of each individual muscle, especially of the deep musculature. In addition to fasciotomies, compartment syndrome with fractures must get some sort of stability at the time of fasciotomy to prevent further muscle injury. For the tibia, this is usually an intramedullary nail. In the forearm, this is open reduction internal fixation of both the radius and the ulna. But external fixators can also be used if necessary. We like to use wound vacs, or negative pressure wound dressings, and a vessel loop technique where we use vessel loops to keep some tension on the skin edges to facilitate later skin closure of the fasciotomy site. We bring these patients back to the operating room every 48 hours for irrigation and debridement and attempted closure. Usually with the legs, you can close one side or the other at the first debridement, and usually at the second or third debridement, if we can't close the remaining fasciotomy, that's when the patient will get a split thickness skin graft. So what happens to these patients after their fasciotomies once their injuries have resolved? Well, there's about a 25% complication rate from fasciotomies. Studies show approximately 10% loss of strength in the extremity as a result of just the fascial release. And these patients can also develop chronic pain, swelling, as well as cosmetic concerns, and they can sustain iatrogenic injury to neurovascular structures during the procedure. Just think about that lateral compartment of the leg. When you're doing your lateral fasciotomy, you're taking it from basically the fibular head down to the level of the ankle. Well, 7 centimeters proximal to the lateral malleolus is where the superficial fibular nerve, or the superficial perineal nerve, crosses across the fibula and can be damaged during your extensive incision for the fasciotomy. And you need to talk to your patients about this as you're bringing them down to the operating room. But going over the risks and benefits, a superficial perineal nerve injury would not be as bad as a missed compartment syndrome, and you need to explain this to your patients in a timely manner so that they can understand. The OTA stresses the importance of not coming up with excuses not to do fasciotomies. If you believe your patient has compartment syndrome, then you have a duty as their physician to do emergent fasciotomies and to do them well. I've seen fasciotomies that were not complete, and patients have ended up with amputations as a result of this, and renal failure, and all sorts of bad things can happen if you don't do a fasciotomy. You don't do a fasciotomy well, and you don't do a fasciotomy in a timely manner. There's significant morbidity that comes from that for the patient. As orthopedic surgeons, we have a duty to be familiar with all of the orthopedic emergent conditions, and compartment syndrome is certainly at the top of that list. In future podcasts, I'd like to go over some of the other orthopedic emergencies with you to make sure that we all have a basic understanding of the things that can make a significant difference in our patients' lives, that we have a solid understanding of them before we're called on to manage those conditions. I hope you enjoyed this podcast. As always, you can visit us at theorthopods.com. Follow us on Twitter. Let me know if you have any feedback, any topics you'd like to see covered in future podcasts. And as always, I hope you continue to strive for excellence in the field of orthopedics. This is Dr. William Pientka from theorthopods.com. We'll catch you next time. Catch you next time. Catch you next time.